Dr. Kelvis here to finish up part two of chest pain. So the patient has experienced chest pain. It's unstable angina. You're in the ER. The physician discovers that, okay, you do probably have a very severe blockage, coronary artery blockage. If that is suspected and diagnosed, an interventional radiologist, a surgeon, can insert a wire into the femoral artery and feed this up into the heart. And they use a stent to relieve the blockage within the heart, which then can restore blood flow. Time is of the essence in this sort of situation, as once heart tissue has died, there is no way to recover or repair this. Many diseases predispose a patient to having an adverse cardiac event or an ACE or ACE, such as a lifetime of smoking, high blood pressure or hypertension, diabetes, obesity, elevated cholesterol, which is in the medical community is hypercholesterolemia, lifetime of heart failure, or just having a very sedentary lifestyle. Studies showed that genetics also contribute, especially if arrhythmias or electrolyte disorders run in the family. Of course, there's poisons, toxins, and medication interactions that can cause heart attacks, but they're much more rare. If a patient develops a severe infection and sepsis, any underlying cardiac disease at that point becomes magnified and absolutely predisposes them to suffering an MI. Finally, there's trauma and acute blood loss that can result in cardiac arrest, which, again, the risk of that in the setting of trauma is once again magnified in the setting of chronic heart disease. Smoking cessation, exercise, and eating a low sodium diet support heart health. There's millions of studies that demonstrate this. All patients should check their blood pressure at least once a year. You can have this done at Walmart. There's always one by the pharmacy section. You can buy blood pressure cuffs, to do it at home. If their blood pressure on two separate occasions is above 140 over 90, they should see a physician to begin a cardiac workup. High blood pressure is an insidious disease that unfortunately typically goes undetected for many years. So the top number is called the systolic blood pressure, which measures the maximum pressure in the arteries at the peak of a heartbeat. So as the heart is pumping, it's the highest pressure in that circuit that is reached. The bottom number is called the diastolic pressure, which measures the resting pressure within arteries, as the heart is filling with blood again before the next contraction. If the systolic pressure rises above 180 millimeters of mercury, this is called a hypertensive emergency, and they should seek ER care immediately. Above this pressure, the arteries are at high risk of rupturing, resulting in a cardiac event or stroke, which strokes happen in the brain. When a patient is experiencing an MI, the body will naturally increase blood pressure in an attempt to reperfuse a blocked coronary artery. For a patient that presents with hypertension or stable angina, physicians will begin what is called a cardiac workup, and this includes labs to check things like electrolytes, inflammatory markers, among many, many things. An EKG will be done at least once yearly to monitor for any electrical changes in the heart. And this becomes the baseline with which to compare any acutely obtained EKG in an ER visit. Depending on the severity of the patient's symptoms, at a minimum, a cardiac ultrasound will be performed. And this is a non-invasive method for viewing the structure and anatomy of the heart walls, the valves, and blood flow. If the heart walls are abnormally thick, for example, this can indicate that maybe the patient has had hypertension for many, many years, and it's caused the muscle to hypertrophy or get bigger. An ultrasound can detect if valves are closing inadequately also, which would then allow blood to flow retrograde or in the reverse direction, which can be fatal and very dangerous. Ultrasounds are painless and they do not expose the patient to any radiation. A small probe is placed on the chest and typically takes between 1 to 2 hours for the full exam. If a patient has stable angina, then they will undergo what is called a cardiac stress test. And this can be obtained in one of two ways, physically or chemically. A patient is fitted with EKG leads and asked to exert themselves on a treadmill. And as they exercise, if any coronary artery is partially blocked, the electrical pattern on the EKG will change, alerting the physician that perhaps the patient requires surgical intervention. Some patients cannot tolerate an exercise stress test, and they're given medication via IV to simulate exercise. A chemical stress test will identify any electrical abnormalities in the same way. Stress tests are much easier when performed outpatient, which means just outside of the hospital, for those who have regular primary and preventative care, but often they're not ordered until a patient arrives in the ER with an event, unfortunately.